The human vascular system is often treated like plumbing, but repairing it requires precise biomechanical engineering. Inside the angiosuite, clearing an occlusion or sealing a failing artery is a strict exercise in applied physics. A common clinical assumption is that placing a metal stent into a diseased vessel actively forces the artery open. In reality, a stent has no ability to dilate tissue. Its function is entirely passive. It acts as a static scaffold, holding ground to neutralize the vessel wall's physical attempt to collapse back in on itself. We see similar assumptions when looking at massive aortic exclusions. Endovascular aneurysm repair, or EVAR, allows surgeons to patch a ballooning aorta through a tiny incision rather than opening the patient's abdomen entirely. Bypassing that massive surgical trauma drops 30-day mortality by 30%. But a look at the data shows that over a decade, the minimally invasive EVAR offers zero long-term survival benefit over a fully open surgery. To understand why, we have to map the exact physical forces at play inside the vessel, from sliding a simple guide wire past a plaque to the complex geometry of deploying a bifurcated aortic graft. Operating inside an artery means balancing these forces. When a physician miscalculates the mechanical limits of the hardware or the physiological tissue, the result is systemic failure. The first tool used to clear a vessel is the angioplasty balloon. Physicians only inflate a balloon if two strict criteria are met: greater than 50% stenosis, and the patient is actively symptomatic. This diagram shows the rigid mathematical rule for balloon selection. The balloon diameter is sized exactly 10 to 20% larger than the adjacent normal non-stenotic vessel wall. A common error is measuring the post-stenotic dilation, the physically ballooned-out section just past the obstruction. Sizing here results in a dangerously oversized balloon. But even with perfect sizing, in a process called elastic recoil, the stretched vessel wall immediately springs back inward the exact moment the balloon deflates. To determine if the angioplasty failed, we measure the fluid dynamics. If there is a residual physical stenosis greater than 30%, combined with an arterial pressure gradient over 10 or a venous gradient over 5, the intervention has failed. Only when these pressure gradients are met do we introduce a stent. The metal physically blocks elastic recoil, holding the space the balloon created. If a balloon is oversized, the outward radial force exceeds the tissue's tensile strength, resulting in extravasation. The artery bursts open. The emergency protocol for an exploded vessel relies on the guide wire left in place. The physician rapidly reinserts the balloon over the wire and performs a low-pressure inflation just proximal to the rupture. This creates a mechanical tamponade, stopping the bleeding long enough to call a surgical team. Placing a stent directly after a balloon, known as primary stenting, is essentially a salvage operation. It is deployed strictly when the biological tissue mathematically refuses to yield to the balloon's outward radial force. When a stent is required, the physician must navigate a strict engineering trade-off: the physical balance between outward radial force and longitudinal flexibility. This diagram illustrates the two primary architectures. On the left is a closed-cell stent. Because every segment of the metal mesh is connected, it provides maximum surface coverage against the plaque and exerts high outward radial force. On the right is an open-cell stent. Deliberately removing some of the connections reduces the overall radial force, but as the vessel bends at a 45-degree angle, the closed-cell stent buckles, while the open-cell metal smoothly contours to the curve. Anatomy dictates which structure is used. Superficial blood vessels that sit close to the skin, like the cervical carotid in the neck or the superficial femoral artery in the leg, are highly compressible. They require materials that can rebound from crushing physical impacts. To solve this, engineers utilize nitinol, a specialized nickel-titanium alloy. Nitinol possesses a unique physical property known as thermal memory. At room temperature, the metal remains soft and highly malleable, allowing it to be easily compressed into a delivery catheter. But the moment it reaches human body temperature inside the blood vessel, the alloy aggressively crystallizes into a rigid precept shape. Conversely, deep tissue locations protected from outside compression, like the ostium of the renal artery, demand exact millimeter precision. These locations absolutely mandate rigid, balloon-expandable stents to ensure pinpoint deployment accuracy. There is one absolute biomechanical rule for any hardware: never place a stent across a joint space, like the knee. The repetitive mechanical shear of the joint bending will inevitably cause the metal stent to fracture and fail. Hardware selection in the angio suite is never a matter of physician preference. It is a rigid engineering equation solved by matching metallic geometry to anatomical stress. These same mechanical rules scale up to massive structural repairs of the aorta. Intervening with an EVAR graft is indicated when an abdominal aortic aneurysm exceeds 5 centimeters in diameter or grows faster than 0.5 centimeters in 6 months. This chart shows survival rates over a 10-year timeline for EVAR versus open repair. In the first 30 days, bypassing open surgery reduces mortality by 30%. But as the timeline extends out, the EVAR survival curve slopes down to perfectly intersect the open repair line. The long-term total mortality is identical. The hidden cost driving this data is the physical durability of the graft. EVAR patients experience a significantly higher rate of delayed mechanical complications, requiring a lifelong series of secondary reinterventions to maintain the seal. To mitigate these failures, physicians must adhere to strict anatomical criteria for the proximal landing zone, the healthy segment of aorta just above the aneurysm. The neck must be at least 10 millimeters long, less than 3.2 centimeters wide, and angled at less than 60 degrees. Violating these geometric limits guarantees device failure. Deploying the hardware through iliac vessels with an angulation greater than 90 degrees or a diameter under 7 millimeters physically prevents the graft from seating correctly. The most catastrophic risk of placing a massive aortic stent graft isn't mechanical failure of the device, but physiological failure of the patient. Extensive coverage of the aorta can induce paraplegia secondary to spinal cord ischemia. This occurs when the graft blocks critical blood supply to the artery of Adamkiewicz. This distinct hairpin-turning vessel branches off the aorta between the T9 and T12 vertebrae and provides the primary arterial supply to the lower spinal cord. If a patient begins developing symptoms of paraplegia after the procedure, the immediate clinical intervention is emergency cerebrospinal fluid drainage. This lowers the physical pressure around the spinal cord, improving the arterial perfusion pressure driving blood into the tissue. An EVAR does not cure the patient's diseased aorta. It trades immediate surgical trauma for a lifetime of biomechanical vulnerability. Even after a visually perfect deployment, the sealed aneurysm sac remains in danger. If blood finds a way around the graft, it repressurizes the weakened aortic wall, a complication known as an endoleak. This diagram breaks down the failure pathways. A type 1 endoleak occurs when the physical seal fails, allowing high-pressure blood to rush past the top or bottom edges. A type 3 endoleak is a structural failure caused by a physical fracture in the metal frame or graft fabric. Both require immediate surgery. In contrast, the most common low-pressure failure is a type 2 endoleak. Here, systemic blood trickles backward into the sac via retrograde flow from a small feeder vessel, like a lumbar artery. Because the pressure is lower, the clinical management for a type 2 is observation. It is actively monitored for at least a year and only requires reintervention if the aneurysm sac physically expands. Finally, there is the historically significant type 4 leak caused by blood weeping through porous graft materials, and the somewhat controversial type 5 endotension. Endotension occurs when the sac grows from the rhythmic pulsation of the graft wall itself, even without a visible flow of contrast dye. Diagnosing an endoleak is an exercise in precisely mapping a fluid dynamic failure to calculate internal pressures, dictating whether the patient requires immediate surgery or careful observation. The interventional suite operates entirely on laws of applied physics. Every decision relies on calculating the specific interface between engineered metal and living tissue. A balloon displaces plaque to clear a channel, and a stent provides the rigid geometry required to battle elastic recoil. We employ advanced alloys like nitinol because their thermal memory matches the physical demands of superficial, highly compressible environments. Massive aortic exclusions demand perfect mathematical geometry in the landing zones to avoid high-pressure endoleaks or spinal cord ischemia. placing a metal strut into a human artery doesn't guarantee a cure. Long-term procedural survival depends entirely on the physician's ability to perfectly align that hardware with the unrelenting hemodynamic reality of the patient.